Good afternoon and welcome. Welcome to the IUPUI Center for Translating Research into Practice Scholar of the Month discussion series. My name is Steve Vieweg. I serve as the Associate Director of the IUPUI Center for Translating Research into Practice. It is my pleasure to welcome you here today, where in a bit we will have a conversation with our Scholar of the Month, Professor Sylk Sotto. We're so excited that she's here today to join us. But before we get started, we like to share a little bit of information with you to set the stage. And first, we like to remind ourselves that this idea of having a space where we could converse with our translational scholars to learn more about their work and ask them questions and be part of the discussion was the brainchild of Professor Sandra Petronio, a translational researcher, emeritus faculty of the Communication Studies program here at IUPUI. And her work is in the area of privacy management, of messaging and information that we share with one another. Our executive director, who is now stepping down and going into retirement, is Emeritus Chancellor Charles Bantz, who has served for many years as a leader on our campus, encouraging this kind of research that is interdisciplinary, that is involving community partners and students and folks on campus, and using or generating knowledge that we could use to solve problems in our community. So we're delighted that we're having a chance today to dig into some of that research and talk with each other here on campus. Many of you are familiar with Zoom. It's been our lives for the last few years, but we hope that you'll remind yourself to leave your microphone on mute. But later, when we get into the conversation, please turn on your camera so that we can see each other and begin to have a conversation and see each other and talk to each other. You're welcome to type comments and questions into the chat. We'll monitor that as we go along. So you know, this presentation is going to be recorded so folks could see it later. You may want to share that with other folks, but if that makes you uncomfortable to be on camera, we understand that you may not want to turn on your camera during the conversation piece. You will also be receiving a post-event evaluation form. We encourage you, we know you get lots of those, but please take a moment to fill it out. It's helpful for us, but also for our presenters to know what's happening. We have a lot of things going on in our center, and so we hope that you'll check our website out to know upcoming events, but also if you're interested in continuing education, you can go to IU Expand to learn more about how you can get credit for coming to these conversations for your own professional development and keeping track of those opportunities. Ways to follow us include lots of social media. Please like our Facebook page, follow us on Twitter. You can check us out on Instagram. We like to share information about what's going on with our scholars, so it's an easy way for you to know what's happening. There's always exciting things happening. And if you get a chance, visit our YouTube channel where you can see past recordings of various events if you didn't have a chance to see them, or if you want to tell a colleague about, hey, go check this out. It's all right there in one convenient place on our YouTube channel. One of our partnerships is with the library, where we work hard to make the journal and scholarly works of our faculty available freely and to folks in the community. So the way we do that is with the folks that participate in this series, for example, we call them scholars and featured scholars, and we have a place on our website where you can check them out. You can go, for example, to Sylk's fabulous photo, click on her page. It'll bring up some more information about her work, her translational work, and you can see down here links, just a link to her journal article that is housed in ScholarWorks. If you want to go to the top of that page, you can go to the ScholarWorks page of the library and see all of her works, as well as all of the other faculty who have taken advantage of this opportunity. It's a way to get out the work out into the community, and we've tried to put it in one simple place so that people have access to that. Now, next month, we're excited to be hosting Leah Bishop, who'll be talking about ending childhood book hunger. So if you're interested in that topic, put down the date, Friday, June 23rd at noon. That's our Scholar of the Month for that month. She'll be highlighted all month on our website if you want to get a preview of the kind of work that she's doing. But today, now we are excited to welcome Sylk Sotto, who is an associate professor of medicine. And she's the Vice Chair for Faculty Affairs and Professional Development and the Vice Chair for Diversity, Equity, Inclusion in the Department of Medicine at the IU School of Medicine. And today she's going to lead us in a conversation about restoring trust and trustworthiness. So welcome to you, Dr. Sotto. Please take it over and help us get started into this important conversation.
And I will take closed caption of the PowerPoint. So if individuals are interested in the transcript, you can see that through Zoom. Thank you again very much for inviting me to give this talk. For those of you that know me, know that the most exciting part really happens during the Q&A, as I have no problems having a great discussion. So the topic of this talk is I am interested in helping restore trust, perspective on trust and trustworthiness in biomedical research. I have no conflict of interest to report, no commitments or anything like that, except that my bias will come through in all of my presentation and probably in my discussions as I see the world through an equity lens. I want to also take the opportunity not only to thank you for the invitation, but also thank the Indiana Clinical and Translational Science Institute because they do support this work and the work of All In for Health. We will talk about trust and trustworthiness, and I will talk specifically about two studies that we have done through All In for Health that are related to trust and are related to community participation in research. With that said, we will leave plenty of time for that discussion. So first of all, I would like to start us with trying to define trust.
So Dr. Sotto, if you'd like, I'll just share for the listening audience the things that I'm seeing in the chat. So we have honesty, feeling safe, another honesty, believing in others, doing what you say you will do, being reliable, having faith in, feeling safe to be honest, integrity, comfort, believing in someone.
Mm-hmm. Wonderful. Those are all great. We know that, and again, I hope that I'm showing the right screen here.
Yes,
but
you are.
We know that trust is essential to building and maintaining, obviously, mutually respectful relationships, especially when it comes to partnerships involving patients and community stakeholders and researchers, etc. There is obviously in that relationship with patients, community members, researchers, etc. There is an inherent imbalance of power. Patients and community members who inform the design and conduct of our health research rely on us as researchers to be honest and willing to protect them from harm. And this is obviously really, really important. And in efforts to build that trust, we have changed the notion that individuals are simply subjects to our research. That's why we changed the language to talk about human research participants. Or in many instances, we're really talking about individuals that are co-producing research along our side, especially when we're talking about community-based participatory research or community engaged or community-led research. We're engaging with them in ways that we have built them into consultancy roles, advisory board roles, and even patient and community members becoming co-investigators or principal investigators in a lot of research. Hopefully, this change of roles really increases the importance of their participation, but also the importance of trust amongst researchers and community members. I would like to point out that Consuelo Wilkins actually talks about trust in ways that are essential to engagement, that after decades of still community engagement in research, we're still thinking about trust as an elusive thing. That an individual may have trust in a specific researcher or the research enterprise, especially us as an institution of higher education and academic health centers, but there are a number of factors that truly influence that level of trust. A lot of my time is also spent talking about research ethics, and of course, we spend a lot of time talking about research atrocities and medical atrocities that have happened throughout history that have in many ways taken advantage, especially of historically underrepresented groups, or at least those that have been marginalized in our history. But despite that, we still follow the importance of trust. We follow similar strategies and discuss them as best practices for trust among research participants. But Wilkins and her group really talk about, we're only beginning to talk about patients and community members who are involved in research as collaborators and partners. One of the things that we know about community engaged research is that it's very much centered around trust. And this is not a lesson in community engaged research. I'm sure that you have had plenty of talks, and we have excellent scholars within Indiana University about this. But and the gist of it is that in building trust, we really try to have effective communication. We really try to build or have this respect, show transparency in everything that we do, that we're truly engaging in a bidirectional relationship, and sometimes more than bidirectional, right? If we consider who are our community health partners, et cetera. The importance of follow through also comes a lot when it comes to trust and how people define trust. The importance to really following through on your commitments and what you set out as expectations for particular projects or even discussions. Then again, the importance of providing training and resources, and as researchers really demonstrating humility and curiosity. So the role cannot be obviously underestimated or undervalued when it comes to research. Without this consistent effort in trust and building strong relationships every step of the way, we really would fail and fall far short when it comes to the success of what we're seeking to achieve. We also know the consequences very well about not having the trust of the community, and also when it comes to losing trust in our own research. It might show up in many ways, in the way that we design research or we interpret our findings or things of that nature, that we show stereotyping, especially again when it comes to communities of color, that we actually may show some tokenism. The inability to engage certain communities is certainly an issue in biomedical research, but ultimately the consequences of not having trust is this poor health and research outcomes, which is what we're trying to address as an academic community. Obviously, the main consequence and the reason why I'm here today is to really talk about the big issue of mistrust, right? We can talk about trust and we can talk about trustworthiness, but we also are fully aware of the consequences of bad research that involves, again, the exploitation of vulnerable populations. And, you know, earlier, Stephen, you mentioned privacy, right? So invasion of privacy, failure to maintain confidentiality, and all those things that lead to mistrust. We have a problem of mistrust in this country, and this has come up recently from the Pew Research Center in their February report, where they actually talk about the partisan differences over trust in medical scientists. Scientists continue to widen, especially since the coronavirus outbreak. There is some interesting information about your political affiliation and how much confidence in medical scientists and scientists you have, how confident you are that those scientists are acting in the best interest of the public. Race and ethnicity also show up, as well as education, and how this shapes up. So you can see here that there is a decrease in trust from the public with medical scientists all the way to indeed the militaries. Here's another one that also shows up, race and ethnicity, and you can see again the decrease in trust by this specific groups. So we know that mistrust is a problem, and we also know that we're losing trust from the public in what we do every day. So the factors and forces behind this distrust, WMC talked a little bit about this, and also in the context, again, of what we just saw with the pandemic, that the public has been overwhelmed by too much information and the growing polarization. And of course, this information has not been quite accurate, right? That there have been disinformation campaigns by many entities, media environment that rewarded outrage, and the increasingly public nature of scientific research. Now, that last one, it's actually a really good thing, right? We want our research to reach the public. However, this information has really created barriers to that trust, as well as transparency and confidence in what we're putting out there. So, as I mentioned, in thanking the Indiana CTSI for support of this research and also for All In for Health, I wanted to tell you a little bit about All In for Health. So All In for Health is an initiative by the Indiana CTSI, for which I'm director, but I actually have a great team that are really the doers of everyday actions. But our focus is certainly on a community academic partnership dedicated to helping improve the lives of Hoosiers by increasing health research literacy, as you see here, promoting health resources, as well as opportunities to participate in research and clinical studies. At the end of this session, I will put in the chat the link, because I want all of you to register, not only for All In for Health newsletter, but also to be research participants. And don't be afraid, it's not all clinical trials. We also have simple surveys that you can all fill out. But we decided to actually ask a few questions about trust to this group of individuals. The All In for Health group is over 13,000 volunteers that are receiving the newsletter and have indicated interest in participating in research. The first study was, do they really trust us? And I will tell you a little bit more about that. And the second one just happened out of the blue. And it was a question about their participation in health advisory boards, such as the one for All In for Health. So for do they really trust us? We really wanted to know and measure trust in biomedical research and healthcare organizations. So, what would be, what can be a better group than individuals that said, yeah, I'll sign up to participate in research, right? Then we also wanted to think about ways to use the data to improve recruitment as an organization. Again, we are, part of our business is to be able to provide more access to health care, and obviously participation in research is really an important part of that for many communities. So we had 3 scales that look at this, and then at the end of the day, we had 663 participants. I will skip the Mentimeter because it wasn't working very well, and that will leave us more time to talk. But the highlights of this particular survey, from what we gather from the 663 individuals, as you can see here, is that 50% of them disagree that patients get the same medical treatment regardless of race and ethnicity. 67% think it is safe to participate in medical research, yet 79% had never been asked to participate in medical research by their doctor. Right? 30% think that medical researchers act differently toward minority participants. And 10% believe that medical researchers select minorities for their most dangerous studies. And some medical research projects are secretly designed to expose minoritized groups to diseases. Now, if you don't find this information problematic, maybe that would be the best discussion at the end of this session. But certainly we were very much alarmed by this data, because I want you to remember that these are individuals that have volunteered to participate in research in the state of Indiana. We also asked participants to tell us a little bit more about what would make them more comfortable to participate in research. And there were two main answers there. If they were asked by their doctor to participate, and if the institutions involve better education programs and public messaging about medical research. That would be the way that they would trust biomedical research participation. In addition to that, of course, as an equity scholar, I have to ask additional questions and look at the data. And out of those 663, 70 of them represented historically marginalized groups. And although I'm not going to go through all the data, I want to highlight 5 important aspects of that data. So these are statistically significant, but I want you to think about this in terms of the difference between views of the historically marginalized groups in biomedical research and the white groups in this biomedical research. So again, there's differences in it's safe to participate in medical research. Most medical research would not lie to people to try to convince them to participate in research. So that is different. Some medical research projects are secretly designed, again, to expose minority groups to diseases. In addition, to get people to take part in a study, medical researchers usually do not explain all of the dangers about participation. So again, you can see difference here. Medical researchers act differently toward minority participants than toward white participants. And again, you can see the difference of 54% versus 74%. And patients get the same medical treatment from healthcare organizations, no matter what the patient's race or ethnicity is. Again, you see that difference of 81% and 68%. So obviously we wanted to reaffirm the importance of understanding our community's trust in medical research, but we obviously understand that we have to critically assess our own trustworthiness. And that is, again, the secondary aspect of this talk. How do we make ourselves as academicians trustworthy? And we should critically reflect on the authenticity of those efforts. So in terms of the study conclusions for do they really trust us? Again, I said that we were alarmed. As a reminder, these are individuals that are in the volunteer registry. But we also know from the literature that trust in scientists has been below pre-pandemic levels. So what does that mean, again, for our registry? Unfortunately, we didn't measure trust years ago. So this is our first trust measure within that registry, but it makes us wonder, right? Has it always been at this level? Do members of our registry still believe that research truly jeopardizes the lives of minoritized groups and especially Hoosiers in Indiana? Of course, we have the reaffirmation that understanding our community's trust and really understanding our own trustworthiness are important. Secondary aspect of it was also looking at our All-In for Health. So this is purely anecdotal at this point. We were looking at our health advisory board that really informs a lot of what we do and provide feedback. And they are amazing members from the community in the state of Indiana. And we had 4 or 5 open positions for board members. So we decided, let's ask if those individuals would be interested in participating. 488 individuals contacted us and said, I am interested. I am interested in being part of the health advisory board. That is amazing. What also was amazing is the selection process, especially when you're looking at 488 individuals. So we actually looked at the motivations and interest of individuals in participating in health advisory boards, and you can think about it as well as community advisory boards, especially in the interest of advancing research. And these are some of those that come up, right? Their desire to share experiences, They had training and education. A lot of them were also members of Indiana University or alumni, or if they wanted to give back to the institution. They had previous experience in boards and participating in research. But the three main items were, they were caregivers, they wanted to contribute to the greater good, and they had some personal diagnosis related to that they wanted to help advance research on. And you can see also motivations related to change and the ability to advocate. So with that said, we also feel that these items inform how we can make ourselves trustworthy and how we can also think about the trust from our community members if we really tap into the good that they want to do in relation to biomedical research. There are plenty models out there, and of course, in translating research into practice, we have to think. I have to mention, frameworks, and I have to mention the practical implications of the work that we're doing. This is also from Dr. Wilkins' group, and they talk about the dimensions of trust. I'll mention some of these as they also came up as Stephen was reading what you thought about trust, right? Honesty, the importance of communication, confidence, again, the belief that you are involved in a relationship with a reliable party, right? In this case, other researchers, that there's competence, there's fairness, there's safety. I talk a lot also about cultural safety in research as a model. And again, believing in the institutions, the processes and policies is really important. In addition to that, again, how do we become trustworthy, or what does trustworthiness mean? They talk about being easily reached as a researcher, being approachable, being attentive, being empathetic, honest, humble. Again, cultural humility is one of my favorite things to talk about, and then respectful. And then again, and when you put all those pieces together, the strategies to enhance and engender trust are easily, you can guess them, right? Balancing the power dynamics, really making everybody at the same level and contributing in many ways in the same level, being transparent about the goals and motivations. Why are you addressing this particular issue? Why you're going to that community? Developing cultural humility, the resources, effective communication, and then again, establishing a pattern of fulfilling trust. And again, that goes to the follow through. Who are we if we're not following through on our research and outcomes and findings and what we do with those? So with that said, there's obviously ethics involved. I will not dig too deep, but I want us to think about trust and trustworthiness and where we have been, again, thinking about where research ethics and integrity policies have led us to, that just because we have system that is based on research compliance doesn't guarantee us that there is a place for trust, as we have seen as far as recent decades, really research atrocities that have happened within our compliance system, within our U.S. government rules and regulations and compliance. Obviously, the lack of trust is a threat to what we all do, not only from an education standpoint, but from the biomedical research that we're doing. And then again, that trust is truly at the heart of science. So trust can be reinforced in many ways through the design and continuous improvement of our equitable partnerships, especially with communities, in the way that we co-produce, co-learn, we share resources, we seek community input. How do we actually invest and utilize the resources to serve the needs to the community? That involvement in all aspects of research and healthcare services design and implementation. So all these aspects are really, really of importance. So this all means that doctors and health professionals and researchers need to better understand the nature of the credibility challenge that we're facing right now. So we can indeed craft effective countermeasures so we can really strategically respond to disinformation or misinformation on social media and other venues, to the way that institutions are working with trusted community leaders to educate the public, to educate government agencies, and really trying to participate in these disinformation wars that we see out playing out. Just in general, I really hope that we can move trust to a critical public health type of lens, in which we're really thinking about the status quo in ways that define the problems and break down fundamental assumptions that we have. Trust obviously is critical, and it has been critical in the research area of community engagement and others. And it's actually at the very core of what we need to do. But I also would like this opportunity to push a little bit further and say trust is really not the be all all things, right? That we work very hard for this trust, especially in community engaged research, but it's time that we also expand and see the other things that are playing out that really can be seen by applying a critical lens, not only to the research that we do, but also to health promotion, the political economy of health, and related fields, and the list goes on and on. I would like to end the talk, and I think Nori and Stephen will be very proud that I'm ending on time, with a poem. And I know that many of us, especially doing biomedical research, we do not bring this socio-behavioral aspect to what we do. But these are the words that were used by those individuals that said, "I am interested." Okay, I am interested in being part of the research, and I'm also interested in participating in the health advisory boards. And these are the reasons for. So with that, oops. Oh, now I'm going in some different direction. Sorry here. I don't know that I can read it without getting emotional, but here we go. So again, these are the words of the individuals that said, "I am interested in participating. My community, my mom, my father, my brother is hurting. I am hurting. Diseases and illnesses have claimed too many lives. I want to help. My identities are vast. I'm a veteran, a caregiver, and a health professional. I am transgender, low income, a teacher, and a student. I am a patient, a Black woman, and a parent. I have worked and I have tried. Above all, I have strong ties to this community. My voice is valuable to these discussions. I want to change the way minorities are treated. All Hoosiers deserve reliable healthcare and adequate representation in research. I want to be helpful. I want to help. I love helping. I am interested." And with those participant voices and in their own words, I will end the presentation right now. And I hope that we all work towards not only gaining the trust of individuals and communities in the healthcare that we provide and in participating in research, but that we work extra hard in making ourselves trustworthy. There's no, purpose in trying to gain trust without thinking about our own trustworthiness and the work that we do. So let me try to escape there. Okay, am I all with you right now? Yep.
Well, thank you for setting the stage for what I hope will become an interesting and wonderful conversation. And this is the time for our participants to turn on your cameras and join the conversation. And let's begin to open it up for what questions or comments do folks have that they'd like to share. You could just raise your hand or perhaps unmute. We'll try to watch that. But I think Dr. Sotto would love for us to engage in some conversation.
I love conversation.
Yeah.
Question for you. If you were to take a look and do that survey among your health professionals, what differences would you see between the professionals who are doing the research, delivering the care, and those who are receiving it?
Mm-hmm. I really do not know the answer. May I call you Ken? Is that?
Yes, please.
Okay, you can all call me Sylk. I really do not know the answer, Ken, but I can tell you that there was one question in the survey. And for those that have seen this data, they know that I always find it kind of funny. So we have presented this work twice already in the Indiana CTSI and the CTSA communities around the country. And the one stat that inevitably every physician, provider, and biomedical researcher points out is the one that says that 40% of them, that 40% of the participants think that medical researchers do this for selfish reasons. And they all, stand there in front of the poster, or the conversation inevitably goes to, but I don't do this for selfish reasons, right? But when you talk, we had obviously focus groups also going through each of the items, Ken. And when you talk to individuals, they're very cognizant about the fact that we do the elitism, or how elitist academic medicine can be, thinking that we do it for papers, that we do it for grants, that we do it for the recognition and awards and things of that nature. So that's where their mindset is, that you're doing this for other reasons other than really the greater good. So anyway, I just put that out there as the one stat that I think is interesting, how all of us react to that notion that we do this for selfish reasons. Do you have ideas, Ken, on how?
Well, I have concerns. The reason I'm on the call, I'm not in the not on the medical side, but I do a lot of work on leadership, and one of those elements that really sits at the top of it is really trust. And that's really what you're talking about, is how do we create that trust? And I think in the medical community and in the research community, there are these ancillary issues which I think probably get in the way of the trust that should be there. And you just identified one of those. I mean, I think in the university, there are some professors, there are some people that are seen as elitists and are doing things for their own best interest, which then certainly diminishes the value of trust. The other thing that concerns me about the medical community is that there are so many ancillary things going on with that are around the community. Those of us that get healthcare are caught in the middle of insurance and access and all these other things, that those also, I think, tend to taint how healthcare really is. And yet in my own personal experience, I've never felt any better about any practitioner that I've had that's done work for me or my family. And yet I see the issues around it, like the insurance or the other stuff, really getting in the way that taint the real value in what I think the medical professionals are really trying to do. So I see that as kind of a cloudy problem here, that even when you survey people, it's hard to dismiss those other factors that are going on.
You're
on mute again, Sylk.
You're correct, Ken, in that, we use these 3 trust scales, and it was mistrust in biomedical research, distrust in healthcare organizations, and mistrust in healthcare providers, or something along those lines. And each of those scales we tested with focus groups to make sure that they were still relevant, and none of them really asked a question about those ancillary aspects of healthcare, right? We didn't ask questions about, insurance, and how has your experience been, navigating through that? Also, the trust scales talked about healthcare providers in general, right? Like biomedical research. And the question that I also get often is like, well, did they think about healthcare providers in general, or were these also thoughts about their primary care physician, right? Or how they interpreted healthcare organization. Is it really about clinical? Is it about IU Health as a whole, or Eskenazi, or things of that nature? So I think that there's obviously a wealth of information and conversations to still have with individuals to try to get to this meat of trust in healthcare organizations and biomedical research.
Yeah, I would just hate to see the practitioners that you're working with, the researchers that you're working with, see that data on trust and feel badly about it without understanding these other factors that I think really may have an impact, when they in fact are doing a much better job than perhaps they're getting credit for.
Thank you, Ken.
It strikes me interesting that it sounds like what you observed, Sylk, in some of the researchers looking at this information is that it's a mismatch for what they think is how they're being perceived. And so that's an important opportunity to think about it. And I was reflecting on, in my work in the field of disability and the work that I do, that the disability community in the recent years has become very strong and comfortable to say nothing about us without us, to push back on that perception that you're coming up with ideas or research, or but without including us. And that was a piece of what I was hearing you talk about around the research aspect, is how do we build trustworthiness, might be including people in the discovery and in the planning, and then that might change the perceptions a bit too, about and help us to understand some of those other ancillary pieces that might go into it.
Yeah, I would like to say one more thing about that. So one of the questions that, again, my interest in that intersection of research ethics and health equity, which trust, falls in there, is the fact that asking in these focus groups, and we will continue to try to do these focus groups throughout the summer, asking individuals about where the source of mistrust and healthcare providers and biomedical researchers is not often brought up from Tuskegee's syphilis study or some other, atrocity, right? It's not that individuals are, unaware of these issues, but there's also a disconnect. The one thing that always comes up is the way that they were treated yesterday in our healthcare system. The way that their aunt, their grandma was treated in the healthcare system. So for us I just want to highlight this piece because I did admit that I was going to show my biases. So there's that. But, that for us to hide many times these individuals are not participating in research because of, these things that we did in the past because of history, and all those things might bring some truth to it, but it's also how we are navigating the healthcare system right now. That also feeds into how people ultimately also participate in biomedical research.
Who else has a comment or a question?
I was just at a conference last week, actually, and some Canadian presenters, a dual US-Canadian conference, and the wonderful things presented on research, engagement, and participation from the Canadian perspective, who have a legislation now that requires, when you have government-funded research, that you have individuals and community members involved from the beginning to the end. And they were sharing some of the things which they have learned as scientists by having community members engaged from the beginning to the end. And one of the most potent benefits they found was when you actually try to do health literacy and you're a scientist, it's really hard. It's harder because your vernacular and your norms are so set in science. And so that's one thing. All of the reports from the scientist participants was about the benefit of having that voice to translate your work into work that is digestible by the very people that you're trying to hit. And it was such a beautiful translational benefit to having that participation. So, and I know it's in Canada, it's easier because it's required and always makes things easier. But I wondered how far we are along in the US was thinking about research and community participation, and you know, are we moving closer to that where it becomes the norm?
Yeah. I don't know that I have the answers, and that is part of me demonstrating cultural humility. I don't know that I have all the answers, but I have to say that I'm very hopeful, because indeed more, at least from the federal grant lens, thinking about National Institutes of Health and others, that there is this push to include community advisory boards or health advisory boards, to include community members in the research itself. So I believe that we're moving in the right direction, but I am not sure again if this will be such Canadian mandate for everything that we do, but certainly something that is being asked of us to really incorporate, and making sure that we're doing that. As part of our professional development programs, I'm running one now on health equity and research scholars. The purpose of that is really this discussion about thinking about health equity from the very beginning, from the conceptualization of the research question all the way to the dissemination piece. So in your comments, it also made me think about the dissemination piece, right? As in academics, we're really writing the journal article, right? Like, how many of us really try to draft that one page, except for our health communication scholars and other individuals, but I don't want to put us all in the same bucket. But how many times do we actually write to the community and tell them, hey, these are the outcomes of this particular research study? Or again, we push our researchers to think about dissemination back to the community, especially as we talk about community engaged research. But that is not always the norm for a clinical trial, for example, right? Do we tell individuals, that these are the results? Not really. So that dissemination and really talking to individuals at a level that they understand inevitably should increase trust, right? We're coming back to you and tell you, here's what happened, in a language that is easily understood.
And that might reinforce that notion that you shared about this is for you, it's not for me. So if our final piece is to make a journal article, and that's our end piece, and we're not following through with the end for others to say this is what happened because you participated in this, that might be fueling. There's things that we do that are our norms that just fuel that notion that you have some academic or some benefit for yourself. And even if you think of it structurally, the P&T process fuels that by the requirements that are expectations of you for public. There's only certain ways your work counts. Yes. And all of those structural systems kind of disenfranchise and disempower those voices of individuals, and that likelihood that is the mode by which you will disseminate or share or translate your results to the actual people who participated. There's so many things that we just don't often recognize that are shaping those behaviors and that lack of bringing it back to the community.
Yes, thank you, Barbara. I don't only make one comment about P&T. As some of you know, it's also one of my favorite topics. But in that aspect, indeed, right? Like, we are doing the faculty and individuals that are doing the community engaged research or public scholarship really can be disadvantage in a P&T system that is really thinking about the journal article instead of thinking about the work that our fabulous faculty and others are bringing to the community, with the community, and on behalf of the community, right? So thank you for your comment.
And to clarify for everyone, P&T is referring to promotion and tenure. For those who are not faculty members to know what that is, that's an intense process for people to demonstrate their value and their work within the academic system. And this conversation has been an opportunity to help illustrate the complexity of this work, right? Of engaging with community partners to solve problems, but to meet everybody's needs. And hopefully we've had a chance to get some ideas about how the value of including our community partners as we try to build trust and trustworthiness, but also have more effective work. And this is a time for us to take a pause, officially thank Sylk Sotto for spending time today with us to raise these issues and these questions and have some conversation. And we know that many of you have other things that you need to do today, starting at the top of the hour. So we want to thank you for coming today, remind you to come join us another time. We will stay on board here for a little bit longer for those that haven't had a chance to say something and still want to participate in a conversation. But if you are one of those people that has to run to the next thing, we want to give you a few minutes to make that happen and make sure that you know how much we appreciate you joining us for these conversations to make this possible and helping us advance our questions and our ideas. So thank you, Dr. Sotto, for your work today.
Thank you. And thank you all for coming.